rule of thumb.
Sorry.
No worries. Yep, sometimes it can be a little bit ambiguous. There's definitely obviously ambiguous cases where we have to determine like what we want to do. And we'll see some of those potentially today. So far, normal knee, right? We got normal looking lateral meniscus, body segment, nice block here, nice block of body segment. And then we're getting into our bow ties. So I'm just going to give them a normal body, anterior horn, posterior horn, articular cartilage, nice intermediate signal intensity, overlying the nice thin subchondral bone plate. And we're getting into the intercondylar region. We can see our ACL here, PCL. The ACL is two bundles, anteromedial, posterolateral. Some PCL is two bundles too, and oppositely named to my recollection. And PCL is normally a lot more low in signal intensity than the ACL is, and that's just, I guess, how it is. As far as the meniscofemoral ligaments, they're better seen on PDs because ligaments are low signal intensity, right? And so if we're looking for tiny ligaments that are low signal intensity, we don't want to look on a fat suppressed sequence because everything around it is also dark, and therefore it is more challenging to kind of differentiate them from the adjacent structures. But we see PCL here, we see this structure. What is this thing? Anybody know posterior to the PCL? Sometimes it is implicated in posterior horn lateral meniscal tears in the setting of an ACL tear. Is a colloquial name for it. Starts with W and rhymes with Isberg. Meniscofemoral ligament of Risberg. So Risberg rip, you may have heard before, is the phenomenon where you have anterior tibial translation in the setting of an ACL tear. And because the meniscofemoral ligament of Risberg is attached to the lateral meniscus posterior horn, and it's behind the PCL, so when the tibia translates anteriorly, and the meniscus is attached to tibia via its root attachments, there's like this traction basically because the Risberg can't go with the tibia because it's locked behind the PCL. So you kind of get this ripping traction on the lateral meniscus posterior horn where this attaches, and you can get vertical longitudinal tears. So one of the more commonly missed meniscal tears are vertical longitudinal tears at the periphery of the posterior horn lateral meniscus from this kind of like ripping and the setting of ACL tears most commonly. It would actually look pretty similar to what this looks like. You see some fluid signal intensity there. I would probably hedge in this particular case. I mean, the guy, everything else looks normal. There's no ACL tear, so like, doesn't make sense that they would have a Risberg rip, or maybe they had a prior repair in this area. But that's pretty much what it would look like. You're not allowed to have signal in your lateral meniscus posterior horns. There's going to be some signal where this Risberg is attaching, right? That's normal. But it's not supposed to extend more lateral than like 14 millimeters from the PCL's tibial attachment. So if this is our PCL tibial attachment, if I was going to do this exercise, I'd say, okay, like one slice here, maybe 2 slice, 3 slice, 4 slice. I'm still seeing some signal, 5 slices, 6 slices, still seeing signal, 7, 8. So this is too much signals. In any other case where there's an ACL tear, I'm probably calling a Risberg rip. You should know that our slice thickness is 3 millimeters here, and that's why I'm counting the slices. I just take how many slices, multiply by 3 millimeters, and that tells me how far I've come. Okay, so moving on. Other things I look for, so ACL, PCL, then another most commonly missed meniscal tear is a radial tear through the medial meniscus posterior root, okay? So you should first slice out of your PCL as you go medial. If I put this localizer here in the bottom, you can kind of see where we are. But yeah, first slice out of your PCL, you should have a relatively homogeneous meniscal root. This is not the perfectest one I've seen, but it's good enough, particularly with the next slice being a nice homogeneous triangle. It should be low signal intensity. There should be no truncation of the inner free margins, no abnormal linear signal intensity. Especially in the pediatric population, they're going to have some linear signal from vessels. You're familiar with the vascularity of the meniscus, where basically in the periphery it's more vascular, and as we get more central it's less vascular, so we call the periphery like the red zone, a red zone. The more central aspect is like the white zone or the white zone, and then in the middle we have the red-white zone. So any tear that's like less than 3 millimeters from the joint capsule is more amenable to repair. You can see some of these like vessels here if you squint a little bit, some of this stuff. So we like to talk about a little bit if it's in the periphery or if it's central, just to give an idea of whether it's repairable, particularly in peds patients or if it has to be taken out, unfortunately. But one of the challenging things can be, at least for residents, I've noticed, is like differentiating normal vasculature from meniscal tears in some instances. And you just kind of have to use a two-slice touch rule. If it approaches but does not disrupt the meniscal surface, it does not meet the criteria for meniscal tear. So we're looking for disruption of a meniscal surface on 2 consecutive slices, or if I see it on 1 slice in the sagittal plane, same area on the coronal plane, then that is also sufficient for a meniscal tear. But this is normal meniscal vasculature. So medial meniscus is looking pretty good. Once you get out here, you see a little bit of MCL. So if I see soft tissue edema here, then on the coronals, I'll corroborate on whether or not there's an MCL sprain or not. I have a list of some things that I look for. If it's like a normal knee and I don't have a good explanation for the patient's pain, I think the most common is in Hoffa's fat pad. Is the name for this like triangular-ish fat pad deep to inferior to the patella. And in the superlateral aspect, if we go lateral, we start to see fibula. We'll see sometimes you're going to see some soft tissue swelling here, some edema. So on a T2 or PD, when the fat is suppressed, edema is bright. So we're looking for infiltration of this fat by bright signal intensity. It's not present in this case, but that's indicative of patellofemoral impingement or maltracking. And I think there's a lot of patients walking around with tracking disorders probably that may be leading to accelerated patellofemoral articular cartilage loss. So something. It's just a topic that I'm interested in. So I'm making you guys listen to my rant on it. So the patella looks pretty good. I'm looking at patellofemoral articular cartilage. This stuff is all trochlea. So some people call it like femoral condylar articular cartilage loss, but really it's part of the patellofemoral joint. So on the sag plane, you kind of get a better look at the femoral trochlea, whether there's subchondral cysts, because on the axial plane, we'll see it's just the curvature as you're going through in the axial plane can make it a little bit challenging to assess the articular cartilage. So sagittal plane is a good plane to look for like the trochlear articular cartilage abnormalities. Quad is going to look like this. It's got 4 tendon contributions, right? Vastus medialis, intermedius lateralis, and rectus femoris. So it's got this multi-laminar insertion, and it's not always indicative of tendinosis. Most commonly, it's not. It's mostly just looks like this. Maybe there's some proximal patellar tendinosis. We have one magnet that's Hitachi in Independence that always gives a lot of weird patellar tendon signal abnormality. So if you're looking at an MRI of your patient and there's somebody who's claustrophobic, it's the Hitachi magnet that we have. It's an open magnet, the only one in our consortium. And you're looking at patellar tendon thing and it looks funny, just see if it's that Hitachi 1.2T, because it's not my favorite magnet. So that's kind of the crux. I'm looking at the bone marrow, make sure there's no marrow placing lesions, looking for any marrow edema to suggest pivot shift confusions and stuff like that. But that's my search pattern on a coronal, on that sagittal plane. Coronal plane, similar, I'm corroborating some things. So the ACL, sometimes on the sagittal plane, it looks taut like this, and you might mistake it as normal if you do not interrogate it on the additional planes, because sometimes you will have a tear just from the femoral condylar attachment. ACL is from the lateral femoral condyle, central aspect to the tibial eminence, and then PCL is the medial femoral condyle or inner aspect to the posterior tibia. And sometimes you're going to have some attachments at the root, and it's not necessarily like hanging down, so you won't catch it on the sagittal plane. So you should look on the coronals and on the axials for the femoral attachment. And just make sure it's nice. You're not seeing what's called a fluid cleft sign, which is where you might see a cleft of fluid deep to the attachment of the ACL onto the lateral femoral condyle. And I like to watch it, make sure all the as I'm scrolling down, making sure all the fibers are homogeneous and having like a nice linear morphology rather than being disrupted. Most ACL tears are pretty obvious, but sometimes they're not. So another thing, MCL, obviously the coronal plane is going to be good for some of these ligaments that are, lay out nicely in the coronal plane. So MCL we see here. If I'm trying to figure out whether it's like a grade 1, 2, or 3 MCL, so just as a brief review, 1 is there's no fiber disruption, but you see edema or increased signal within the ligament or soft tissue edema adjacent to the ligament. That's a grade 1 sprain. Grade 2 sprain is if you see edema, but in addition to that, you see some irregularity in the fiber. So for fiber irregularity, it's easiest to track it on the axial plane image where we can see the femoral attachment here in the medial femoral condyle. We can track it clearly inserting onto the tibia. Similarly, the fibular collateral or lateral collateral ligament you can see on the sagittal plane, or I mean on the axial plane going from the fibula all the way up to the lateral femoral condyle. So the axial plane is good for looking because sometimes what'll happen is the posterior fibers are intact of the MCL, for example, but you'll see some disruption of the anterior fibers. Usually at the femoral attachment, in my experience, but it can be anywhere. So if you're trying to grade sprains, you want to look on the axials to see if there are fibers disrupted. If you ever see that it's like kind of like serpiginous in morphology, kind of wavy, that's basically indicative that there's a full thickness tear because there's nothing, it's not attached to anything to make it taut anymore, and that's why it's giving you that like wavy morphology. Similarly, the fibular collateral ligament. Coronal plane, again, I'm just interrogating the menisci and the inner free edge to make sure I'm not missing any radial tears that I would have seen on the sagittal, either missed on the sagittal plane, so just nice sharp pointy menisci. That's pretty much my search pattern, I guess. Pop cysts between semimembranosus and semitendinosus. Has to be between those two tendons, or else it could be a myxoid neoplasm. That's the classic teaching. Pop cysts always arise from between those two tendons. Popliteus tendon, also lateral femoral condyle. You can see coming out, forming a muscle here posterior to the tibia. So muscles, it's not something I'm like discreetly looking at every single time. Like you'll see edema if there's some, if there's a strain or something, it's pretty obvious. It's not something I'm like purposefully interrogating every muscle on every exam just because it's usually obvious. All right, so that's the crux of my search pattern and what we should be looking for. The one coronal plane that we have is the T1, so this is the best for evaluation of bone marrow, or if you think your patient has lipoma or something like that, you're going to be wanting looking at sub-Q fat or looking for a marrow replacing lesion. In your pediatric population, you're going to see a lot of non-ossifying fibromas, or even like young adults, which are just normal. They're not normal, but they're not concerning neoplasm, and they're usually cortically based, so eccentric, based in the cortex, and well circumscribed and bubbly, lucent appearing. On X-ray and on MR, that's usually some people will just ignore them because we don't want to freak anybody out. But I usually interpret them, put it in the body of my report, not an impression, just so if anybody has a question about it, it should be there hopefully. IT band usually catch it before we do, so we don't really see a lot of IT band syndrome on MRI, but here it is. And if we were to be looking, here's Gordy tubercle where it's inserting, we can see it nicely on the T1 weighted sequence, which is better contrast between the low band and the bright fat. But you'd be looking for edema here and where the IT band courses over the lateral femoral condyle. You do not see on this normal EMR. Anything I haven't covered? Any questions? Okay, let's dive into some cases then. The same person came back 5 months later. Okay, so here is a classic sign that we have in MSK rat. You can see hopefully it's a little bit blurrier. Signal to noise is not as good. And then it's still a 3T, but it's our Phillips 3T. The other one was our Siemens 3T, I believe. Let me just, whatever, it doesn't matter, but it's just a blurrier picture. It doesn't look as pretty. Okay, so anybody have a hint or guess as to what the hell's going on in this picture? Let me give you a clue.
Meniscal.
Yeah, meniscal tear. Any particular tear morphology that you can think of? We have horizontal tears, we got radial tears, we got vertical longitudinal tears. We'll just go with those three basic criteria. Yeah, it's a bucket. So this is a vertical longitudinal bucket handle tear. We can see that post one, as I mentioned, I'm looking at the sagittal planes, right? And I want to look for body segment tissue. If I'm not seeing two nice blocks of body segment, I got my hackles up and maybe something's going on. And I'm seeing, this is not a good body segment. It's not homogeneous. It's got too much signal. So we have a relative paucity of normal body segment tissue, which tells me that there's a tear. And so I look at that on the coronal plane to confirm. But as we continue, we see that the posterior horn, this is kind of called ghosting of the inner free margin. You can have ghosting of the whole posterior horn or just part of it. And so we have some relatively normal-ish tissue back here, but this area is not low signal intensity, it's kind of intermediate signal intensity. Okay, so that is one indication, and it's relatively tiny posterior horn if you compare it to this normal anterior horn. Okay, what's this thing? I guess this is the normal anterior horn. This is a flipped fragment in the intercondylar notch. So this is a bucket handle tear with a flipped fragment, and you can follow. So this is the flipped portion can never be more superficial or more anterior than the actual native anterior horn. So here's the flipped fragment. And if we watch it, we keep watching it, we keep watching it, we keep watching it, goes in the intercondylar notch, it meets the rest of the posterior horn as we come back medially. So it's flipped here. Another common sign that we see for buckets is our double PCL sign. So if you're ever looking at the PCL and you think that there's another PCL anterior to it, that's your double PCL sign. And that's another sign for a bucket handle tear. It's just flipped more centrally in the intercondylar notch that gives you that appearance. But so here is a bucket. It's just, so imagine this thing, it would be here, for example, and that's your bucket handle tear. So we got a bucket of the lateral meniscus here. One of my favorite pastimes is finding them on the axial plane because I like to point it out. You can see the nice flipped fragment and a very tiny body segment in contrast to a nice, large, more robust medial meniscus here. Let's see if there's anything else cute to talk about here. A little bit of joint infusion. It looks like it's not an acute injury, something maybe they've been walking around with, not a lot of soft tissue edema. Everything else looks fine, right? It's just that the meniscus looks terrible, and you can kind of see that fragment here again in the intercondylar region. But no MCL sprains, no LCL sprains, ACL looks good, there's no bone marrow edema. Usually you're gonna have an acute traumatic episode when you have bucket handle tear, nobody's walking around. So I don't know, he's probably just had some delay between his MRI. There's no radiograph prior to it, so that's something I'm looking for if I'm trying to grade. If it doesn't add up, like why, what's the chronicity here? Then sometimes I look to see when the plain film was obtained. Okay. Any questions about buckets? All right, let's just start from the top here then. Okay, so one thing you should know about MR is it's not necessarily better than X-ray, right? It's better than X-ray for looking at soft tissue abnormalities and a superior soft tissue contrast, but radiographs have their place. And to be honest, in general, we really don't like reading MRIs in the absence of an X-ray because X-rays are going to show us subtle, Sagan fracture, for example, which is a little, avulsion of the lateral tibial plateau from the capsule that has a high association with ACL tears. Like, we're going to miss that a lot of times on an X-ray. Also, mineralization like hydroxyapatite. We think about it a lot in the shoulders and the cuff, but not always thinking about it in knees or buttocks region. So I just think it's something also commonly maybe missed because we're not thinking about it. But I will draw your attention to this calcific density. So in radiology, we have a discussion about are things ossified or calcified, right? Because the differential is different between those two things. So calcified structures do not have bony architecture, whereas ossified structures do have bony architecture. So bone has a cortex, it has trabeculation. This thing looks kind of like amorphous and cloud-like to me. It doesn't have a peripheral sclerotic rim of cortex. It's got some, maybe you could hallucinate some trabeculation in there, but it's not like nice trabecular markings like this bone. So, I'm not sure. I would maybe consider this as being calcific. And so this patient's presenting with knee pain, and we're looking at the MR now. And they've got an old knee, right? We see a bunch of osteophytes, there's some articular cartilage stuff, but the bone marrow isn't super oedematous. And so that makes me think that maybe the OA is not really the etiology for their pain. But when we get back here, we start to see some signal within the bone, we start to see some signal adjacent to the medial femoral condyle, and bright stuff on a T2 weighted sequence means fluid, which generally can mean swelling. and inflammation. In this case, we see this goober of low signal intensity. If it was ossified, it would be low. If it would be low on fat suppressed images, it would be bright on non-fat suppressed images because bones have fat in them, and so something that's ossified is going to match the bone signal intensity. So it would be bright on T1, fat suppressed should be dark, but this goober is dark on both of these things. That indicates that it's calcified, not ossified. A bunch of soft tissue edema near the medial gastroc origin is indicative of hydroxyapatite deposition. So I call this one calcific tendonitis, and just something to be aware of, because like the common things you're going to see, but sometimes maybe we're not thinking of it. It could be something you think of to figure out why your patient is having pain. We'll see a bunch of common things too here, but sometimes you got to think of some of the less common, or common but not in this general area. A lot of PFOA, we can see the articular cartilage is pretty denuded here, and we can see areas of subcondylar edema. Here's some normal intermediate signal intensity articular cartilage, lateral patellar facet, relative paucity of articular cartilage. No, it's all bright. So if you see too much brightness, that means there's fluid occupying a space where there should be cartilage. So here we see some cartilage. Here we see relative absence of cartilage because there's so much fluid there replacing where the cartilage should be. Femoral trochlea, I kind of mentioned, we see some cystic changes and edema. And on the sagittal plane, if we have a good one, you can see that on the sagittal plane too. So I'm looking at femoral trochlea a lot on the sagittal planar. Okay, let's try this one. Patient. It's a bad name when it's patient. Okay, so search pattern. Let's see. Okay, so I'll give you a couple images here. You have a positive arrow sign. But let's see. So I'll leave you with follow this thing. And we talked about interrogating things on all three planes. Like, look at this thing, starts here, you see it go all the way here. This thing is nice and robust here, but we see it course towards this general region, but we have a little bit of fluid there, and it seems irregular and like it's kind of like bending here. It's not a normal morphology for what's the structure. Yeah, PCL. So this is the PCL tear. Dashboard injury is the common. We can see here PCL. It's never really making it towards the condylar attachment. It's very bright, which is very abnormal for these PCL. It's normally homogeneously low signal intensity. ACL is kind of bright too, but we see some hyperintense ACLs. We see a lot of myxoid degeneration of ACLs or mucoid degeneration, but less commonly do we see mucoid PCLs. So this is a full thickness PCL tear from the femoral attachment. Dashboard injuries or roller skaters. I think I've seen them in a few roller skaters who would fall onto their knees.
Yeah, we see it in football players with direct falls.
Direct falls.
Or direct blow.
To the anterior knee.
Yeah.
Yeah. Sounds painful. The other thing we'll see is, so this is our PCL. We're going to start going into the medial meniscus. No root, really irregular roots, really irregular roots. So this is a root tear of the medial meniscus, which actually a little cutesy thing here too is we see this little thing that's bright on T1 or this PD non-fat suppressed sequence, and then it becomes dark. You can see that. That's a meniscal ossicle. So most commonly seen in the posterior horn medial meniscus. It's pretty uncommon in general, but it can be more prone to tearing because there's a chunk of bone inside of your meniscus, but that's known as a meniscal ossicle, and you can usually see it on X-rays too. Okay, but this is a meniscal root tear. Sometimes I go to the coronals and try to corroborate that on the coronal plane. We can see here nicely. So here's a normal lateral meniscus, has a pretty homogeneous root attachment here. Here, medial meniscus, you kind of see this vertically oriented signal intensity, increased intrasubstance signal and disruption, which results in extrusion of the body segment because it's no longer attached. Something about hoop stress or something like that, and then you get accelerated articular cartilage loss and insufficiency fractures, things like that, but less common probably in your patient population. Speaking of MCLs, so here's nice coronal plane, and the MCL anatomy has deep and superficial components. The superficial component is, what we most commonly look at and think of, but the deep component consists of your meniscotibial and meniscocapsular ligaments. So here, this was called the full thickness MCL or grade 3, including both the superficial and deep components, because the meniscocapsular ligament is not really making it anywhere. You could argue, maybe there's one thin like fiber here that's still intact, but functionally it's a grade 3, right? There's basically nothing holding on here anymore. A lot of soft tissue edema, obviously, in this acute injury. And here we can interrogate that PCL, that MCL, and basically, yeah, it's practically not attaching nicely to the femoral condyle there. So we have a high grade 3 MCL, we have a grade 3 PCL, relative sparing of the ACL. Posteral angle corner structures don't look terrible bad. And that's pretty much it. Maybe there's a full thickness medial patellofemoral ligament disruption associated with this full thickness MCL tear that's allowing some joint fluid probably to get out, causing all this marked soft tissue edema here in this medial aspect of the knee. Anything else cool here? I don't think so. Okay, let's move on. Any questions so far?
Trying to absorb it all. Sound
Good, yeah, that's good. Okay. There's some craziness in here too. This is gonna be, so what do you think about this X-ray? Anybody? Yeah, big OCD, right? So in your population, probably it's most common traumatic injuries, but a lot of things can lead to OCDs, and this is one of those things. We're gonna see here. So what's going on here? Yeah, this is a lot of AVN basically. So femoral tibial AVN. What we have is the double line sign. So we can see that there's the serpiginous areas of abnormal signal, but you see this double line where there's a bright line next to a dark line. The bright line is granulation tissue. If you look under a microscope, and the dark line is the leading edge of the necrotic bone. And so that is what the double line sign is. There's some soft tissue edema. We can see some periosteal edema from this AVN, but AVN can lead to fragmentation of subcondylar bone plate and can lead to OCDs or OCLs, I guess. And so would you guys think that this is is this stable or unstable? Unstable, right? So what determines that? This is what happens when you answer questions people ask if you have more questions. Anybody know? Maybe group discussion. Okay. So fluid signal intensity, right? It's kind of intuitive, right? If a OCD, so to describe an OCD, you want to see some irregularity of the subcondylar bone plate and some irregularity of the overlying articular cartilage. Usually in the traumatic setting, that's how it works. But this is more like from inside out because the bone is failing. And so maybe we don't see those overlying articular cartilage abnormalities yet. But fluid signal intensity clefts deep to an OCD are indicative of instability. In pediatric patients, there's some alternative things you can look at. If there's a single cyst subjacent to the OCD greater than 5 millimeters in size, or multiple tiny cysts, that also indicates the possibility of instability. So usually that's what we're looking for. If it's equivocal, then you could consider, I guess, just some serial MRIs to see if treatment would be indicated or not. So I guess that's usually how we describe it. And I try to give a size both in the coronal and the sagittal plane. Here, this meniscus is probably also torn. It looks like we have a 2-slice touch rule. There's the signals disrupting this meniscal surface on 2 consecutive slices. Multiple, it's going into this posterior horn area too. So this would be a horizontal tear of the lateral meniscus. Similar appearing medial meniscus. So either really, really prominent vascularity or they've got bilateral horizontal tears. So yeah, the crux of this one was AVN and OCD and just, instability criteria.
So AVN secondary to sickle cell.
Sickle cell, chronic steroids, there's a lot of differentials, but probably sickle cell. See if you have any information. Eval for AVN versus stress fracture. I don't know, in this particular case, it's not a lot of chest x-rays.
What they were looking for, so that's good.
Yeah. You guys, your group is actually best, I would say, at giving history, so thank you for that. Yeah, more than pain usually, so that's good. Okay, this is a cute case I like, I think you will hopefully like too, and I was fortunate enough to have a prior, but another, we kind of talked about commonly missed tears. And so sometimes it's a Risberg rip, which I alluded to earlier, but sometimes it's not a rip due to like tibial translation, but sometimes people just have acute traumatic episodes. I think this person was a wrestler or something, and something happened and they were having lateral knee pain. So this is a normal prior, and I want you to pay attention. Lateral meniscus, posterior horn. You see relatively dark signal intensity here. This is just suppressed fat. If I was going to show you the sagittal plane on a non-fat suppressed, there's just some fat in this popliteus hiatus region, which is the space between your posterior horn lateral meniscus and the capsule, where the popliteus tendon courses through, and you have these like popliteomeniscal fascicles that you can kind of see these little nubbins of tissue that go towards the capsule. All right, but this is all fat, and on this fat suppressed sequence, it's normal dark fat. But patient has pain, posterolateral knee pain. I'm looking at this MRI. I'm like, all right, there's joint effusion. There's got to be something going on, but I'm not seeing really anything. But if we really interrogate this area and compare it to the prior, we can now see that there's a tiny signal, fluid signal intensity cleft at the periphery of the lateral meniscus, but the morphology and like volume of the posterior horn lateral meniscus is otherwise normal. But I called this a meniscocapsular separation. Arthroscopically, it ended up being a vertical longitudinal tear of the lateral meniscus posterior horn that they repaired. So, you know, the patient was having symptoms of instability or locking, things like that. And with the joint effusion, which helped, you know, these secondary signs I find are useful to help me keep looking rather than just being like, all right, nothing's going on here. It just was not adding up. In the cases when it's not adding up, I would just encourage you to take another look for some of these things. And one of those would be meniscocapsular separations, posterior horn, lateral meniscus. We see it sometimes. You can also see one of the things that was freaking me out is that there's all this soft tissue edema here, which I didn't have a great explanation for. Could be a soft tissue contusion, I guess, but I just wanted to keep looking for that reason. And then you can kind of see nicely, I guess, that there's this like cleft between this little thing of tissue and the normal lateral meniscus posterior horn. So I suppose that there's just like a thin area of meniscus that was sheared off here posteriorly. Okay, so meniscocapsular separations, particularly also in the setting of ACL tears. We don't have one in this case, but ramp lesions, which is just like a peripheral tear of the medial meniscus posterior horn or meniscocapsular separation. I'm always looking for those, particularly in ACL tears, because there's an association between those two. While we're here, here's that meniscofemoral ligament of Risberg posterior to our PCL. There's one sometimes anterior to the PCL. You can see it here, known as the meniscofemoral ligament of Humphrey. Just normal structures. They're important to know because you don't want to mistake signal between one of those ligaments and where it's about to attach, like on these slices as a tear, because you're allowed to have signal there until you get further out, 14 millimeters, and this goes on beyond 14 millimeters. It's probably less in pediatric cases, I guess, because the knees are tinier, depending on the age. All right, what do we have here? Okay, this is not, I don't think why I'm showing this case, but anybody know what this is? This is called a meniscal flounce. So it's always generally lateral meniscus. So I try not to use the word always because rule number one for Patrick Getty is anything can happen to anybody. He is an orthopedic oncologist here. He's at the VA now, but this is just a normal anatomic variant. The purpose of this case, don't call this a tear or don't think it's abnormal. If you have a little bit of undulation of the lateral meniscus, inner free edge, it's a meniscal flounce, not a tear, as long as everything else looks good. Let's see if there's any other reason that I put this case out here. I guess there's a little bit horizontal leak tearing of the medial meniscus posterior horn on this non-beautiful image, but Okay, I think that was it for this one, I guess. I mean, there's a lot going on here. I guess the meniscus is torn, the MCL is bowed, and there's some soft tissue edema or bursitis superficial to the MCL. But otherwise normal. Complex be meniscus extrusion contact. Okay, I think it was just for the flaps. Tunnel view is really good for marginal osteophytes, just at these little margins of the periphery central condyles. You can see little tiny bony spurs, which are more obvious in this particular person, but you can see them a lot earlier, particularly in athletes who use their knees a lot. Okay, what we got here? X-rays. Anything catching any? The only thing that's catching my eye is that the patella is not necessarily right in the middle of the femoral trochlea on this particular case. Could be rotated, but keep looking. Here's the fibella, normal. Okay, we'll see what the MRI shows. All right, well, patella's normal, so don't forget what I said. All right. Let's go again. I'm just going through from lateral to medial. So far, this also looks like a 3T. Yep, Siemens, Westlake. So we have 4 3Ts at main. We have 1 here, which is the Phillips, which is the less ideal of the 3Ts, and then there's a Westlake 3T, which is good. So all the other 3Ts are Siemens except for the Phillips one here. Phillips it's fine. I wouldn't like not send patients here. It's just not my favorite relative to the other ones. Okay, here's a good case. So this is why we put it here, secondary signs. So this is obviously, I mean, it's not super obvious. Like I've seen more obvious tears, but there's definitely signal within this meniscus that's linear. Is it disrupting a meniscal surface on 2 orthogonal planes or 2 consecutive slices? So sure, like maybe here it is, or here it is, maybe, but it's not, it's relatively, it's not a slam dunk, okay? Until you appreciate this structure as we come further out, this structure, and this, and it leads to this, okay? So what is this then? What is it when there's a cystic fluid collection adjacent to a meniscus that may or may not be? Let's say it's torn in this case. Yeah, parameniscal cyst, right? So parameniscal cyst is a secondary sign that helps us in equivocal cases. If it's there, then it's pretty much slam dunk meniscal tear because the fluid from the joint is herniating through the defect in the meniscus, and there's a ball valve effect or it can't get back into the joint, creates a parameniscal cyst. That's what we're seeing here, and the tear is probably like further out here in the posterior horn as we were seeing on the sagittal plane, but it's propagating with this like multi-loculated stalk to the posterior medial aspect of the knee. And that's a parameniscal cyst. It can be, again, a secondary sign to help us identify more subtle meniscal tears. You can see it's kind of going from here out to, and it's distinct from this little trace popliteal cyst. I mean, I would ignore this if I was interpreting this exam, but it's distinct from that. We can track it to here, but we cannot track it from between the semimembranosus and medial gastroc. I think that was the crux of this case, parameniscal cyst, and using it as a sign to help you identify some subtle meniscal tears. Right, well, hyperextended knee is not ideal radiography technique. This throws off our insole body ratio, the ratio of the patellar tendon length to the patellar length, which we can use to identify quadriceps or patellar tendon tears on lateral radiographs, but you really need like a knee that's flexed to like 30 degrees to be able to identify 30 to 45 degrees. So in a hyperextended knee like this, it's not going to be a valuable thing to measure, just an FYI. Bones are long and thin, almost gracile appearance. Okay, here we go. What's going on here? Sure you've seen this. Yeah, transient lateral-patellar dislocation, right? So we see marked marrow edema of our lateral femoral condyle, marked marrow edema of our medial patellar facet, indicative of our contusions or osteochondral impaction injuries. Okay, so then there's other things we want to describe. Our job is not done. One is we're looking for any articular cartilage defects. Here we go, there's an axial. So we changed our protocol. There was a period of time where we were getting axial T1s, which kind of helped to look at the MPFL in this region. But we stopped getting them, I guess, because the group didn't like them as much, so we stopped getting them. But you can still evaluate them on a T2FS, T2 fat sat axial, which we will see. But yeah, we can see our lateral femoral condyle is markedly edematous. There's maybe a little bit of an impaction deformity here potentially. So maybe a little impaction fracture. Patella impaction deformities you'll see nicely on these coronals, particularly the coronal T1s. If I'm looking for any cortical defects or like abnormal morphology, we don't have T1s on this plane because it's our old protocol, but I like to go far anterior and see if I can see like a little triangular defect here to see if there's an impaction fracture or if it's just a contusion. I'm interrogating it's usually inframedial patella, right? So looking at whatever I can see here. Sometimes it's like just blown in. You can't really say much about the cartilage. There's an osteochondral impaction fracture, but you won't see defects there because you don't really see much besides schmutz. So then I'm looking at the rest of the patellar articular cartilage, making sure nothing was sheared off that needs to be tacked back down or anything like that. So you're familiar with the tibial tuberosity trochlear groove distance. Really how we do that is we want to find the most superior slice where we see some articular cartilage. You want to draw a line like this one that's parallel to the posterior aspect of the femoral condyles. Then we draw a line perpendicular to that line, 90 degrees going down the central aspect of the femoral trochlea. Okay, and then what we do is we find our tibial tubercle, the central aspect where the patella attaches, our patellar tendon attaches, and we do a MIP, which is a maximum intensity projection until we see that second line again. Then we measure from here to here, and that's our TTTG, markedly abnormal in this particular case. Normal is between, anybody know? Just trying to keep everybody awake. So 15 to 20 is borderline, less than 15 is normal, greater than 28 is abnormal. So they may want to do a Fulkerson or whatever in this particular patient. He follows me on Twitter, just saying, but it's a big deal. So you could do maybe a medialization procedure. The lateral femoral, patellar, the lateral trochlear facet is pretty steep, and this should be keeping the patella in place. There's all sorts of patellar or femoral trochlear measurements one can do. You can do like the lateral inclination angle, which is essentially this angle. You can do a ratio of the lateral trochlear to the medial femoral trochlear facets. You can like draw a line here and measure the trochlear depth. Honestly, I just look at it and I'm saying to myself, is this shallow and dysplastic, or is there a nice groove here? This looks pretty good to me. I think the main issue is probably that how lateral their tibial tubercle is relative. Maybe you start with quad strengthening or something and see, hopefully that does the trick, but sometimes it doesn't if you're a repeat dislocator. It seems. Anybody here ever dislocate their patella before? Yeah, neither have I. Yeah. Okay, that was MPFL. Let's talk about that too. So we want to go basically to the middle slice where the medial patellofemoral retinaculum attaches to the patella. It's probably here. So the MPFL can be sprained either at the patellar attachment generally or the femoral condylar attachment. You can see why someone would like the T1s or the non-fat suppressed sequences here, because if I'm looking for a dark ligament and it's femoral attachment, but all the fat is dark next to it, like I have no contrast between the normal structure that I'm looking at and the adjacent tissue. So T1 is good in those particular sequences, but I think we're fine without them, but some people like them, I guess, some of our rads. Maybe here there's a low grade sprain, but again, it would be the same thing as the MCL we talked about. If it's like undulating morphology, it's high grade. If there's some fiber disruption, but most of it's intact, that's going to be grade 2. And if it's just some intrasubstantive periligamentous edema, that's a grade 1. Just a little bit of bursitis here, it seems pretty patellar. It's like mind grabbing me and after starting up. Thanks, dude.
Yeah.
Oh, good. All right, disaster averted. Okay, this knee is also looking not great. Look at all this soft tissue edema extending. Oh my god, that looks terrible. Okay, so this is a bad one. There's a lot to talk about here. Everybody, get ready. All right, so peroneal nerve, right? We saw it on the normal cases a few different times. Let's do this. Look at. Okay. Put our crosshair up. Okay, so here it is. It's not supposed to like make 90-degree turns, I'm pretty sure. So that's not good. All right, it's got some sort of injury here, and we're going to further evaluate that on the axials. Here's our biceps femoris, which is not also supposed to be turning in its morphology. It's supposed to be relatively taut, so I'm a little bit concerned that that's torn. There's not a lot of edema of the fibula, which kind of argues against any like bony avulsions, but we could still have soft tissue avulsions, which is usually what happens in adult patients. Here's our LCL. You can kind of see it coming down and doesn't seem to make it all the way down to the fibula. We see this cleft of fluid where all these things should be essentially attaching. So we may have a high-grade posterolateral corner injury here. Popliteus tendon is also torn, so I was reading about this, and the more important stabilizers of posterolateral corner are the popliteus tendon and your lateral collateral ligament. So you want to make sure you're evaluating those. And here, this is your popliteus tendon. It just stops right here. It doesn't like make it all the way to where it's supposed to go. Lateral meniscus looks pretty decent. Popliteus tendon coming through here, not bad. Here's that meniscofemoral ligament of Humphrey. It attaches, and this signal stops basically there. So this is probably not a Risberg grip. Normal. This arcuate ligament back here. So you see this is your lateral genicular arteries. Anterior to that, you're supposed to see an arcuate ligament, which sometimes we catch, sometimes we don't. Posterior to that, you see your popliteo.
Response to the floor, room 504. Rep response to the floor, room 504. Rep response to the floor, room 504.
See, this is the high grade posterolateral corner. ACL is blown to smithereens, right? We lose the normal morphology. Yeah, I mean, this is markedly abnormal. I don't know what else to say about it, except for there's no fibers that I can see going from one place to another. So it's a mid-substance ACL tear. PCL. And then normal-ish posterior, no meniscal tear. So if there's like one lucky thing that happened to them, it's a meniscal tear. Quad, patella, but everything else. Okay, so let's check here. So collateral, we're gonna follow it. Here it is. Looks like Alternian stuff. And still there, but then it just disappears, right? I don't see fibula yet. Oh, there it is. Okay, so but it never makes it to an attachment. And we begin to see a little bit of fibula. So that's a grade 3 LCL. Again, popliteus tendon starts in this little divot in our lateral femoral condyle, and it just stops right here. It doesn't seem, maybe there's one little thin fiber attaching, just for fun. You see this one little thin fiber attaching, but it's not a robust attachment by any means, or origin, I should say. There's a little defect in our lateral patellofemoral retinaculum, positive arrow sign through here. But look at this peroneal nerve. Here it is. Here it is. Here it is. It's coursing anteriorly, and then here it's like very thick edematous and taking these abnormal contours. So I wouldn't be surprised if they had some degree of neuropathy resulting from this injury. For MCL, we can see that there are fibers, right? I mean, it starts here and it goes down, goes down, goes down, goes down, goes down, and attaches to the tibia. I'm not seeing any of these fibers really disrupted. I'd probably call this a grade 1, but I could see maybe someone arguing, okay, it looks like maybe some very far anterior fibers. I mean, this person's not gonna be walking around for a while, so like, I'd call it grade 1 or 2, it doesn't really matter at this point, right? I don't think so. Grade 3, maybe then, yeah, it has some surgical implications, but. And so, yeah, posterolateral corner injuries, a lot of times the capsule gets disrupted, you see this marked soft tissue edema at the posterolateral aspect of the knee and the gastroc and soleus muscles. So if you start seeing stuff here in the soft tissue, start trying to look for any posterolateral corner injury, I would say. Okay, almost time. We've got some more cases, but we'll just do what we can. Any pathology anybody has trouble differentiating? Okay, this is just another one of my favorites. Hydroxyapatite deposition, medial gastroc origin, just to prove to you that it happens. More than one person. We already looked at that guy. Okay, so ACL reconstruction, right? We can see femoral tunnel, tibial tunnel. This is a pretty good looking ACL, nice thick, low signal intensity. It's ligament to ligament tie. But there is something going on here, and that's this thing. So what's this called? Anybody know? This big fibrous structure in the intercondylar notch region in a post ACL repair patient or reconstruction. They say arthroscopically it looks like a eyeball. It's called a cyclops lesion. So this is one of the complications, post-operative complications. It's just arthrofibrosis, scar tissue that forms in the deep aspect of the intercondylar region, and this can result in like inability to extend fully and locking, and so they may go in and debride this, but it just looks. They call it a cyclops lesion because when you go under the scope, it looks like there's like an eyeball staring back at you, I guess. This person also has a meniscal ossicle, I think, if I recall. If we look at this thing, it's dark here, and it's right there. So posterior root medial meniscus, meniscal ossicle, which sometimes you can catch on the x-rays. Anything else here? Okay, so we talked about that one patient's OCD. Here's one. We can see lucency of the condyle here, medial femoral condyle. But if we look up here, we can see a little displaced osteochondral fragment probably. So we go to the MR, we see that there's a large, unfortunate osteochondral defect in this patient. And then, you know, we want to be searching for the displaced fragment because sometimes they can use that, it seems. And so whatever it is should match the signal intensity of bone and cartilage, right? So here we go, bone, bone, cartilage, cartilage. So there's a 16 millimeter, and it looks like you could just plop that thing right back in there, hopefully. I'm pretty sure it's not that easy, but.
So those typically will present locking, like true mechanical locking.
Good to know.
Yeah. And they'll have a fusion sometimes, but not always. Did they have a plain film?
They did.
Sorry, yeah. I had a kid like that recently. I wonder if that's.
This is yeah, 2019, but a lot of.
Yeah, I had a patient like that really recently.
Yeah.
He was kind of interesting because he had actually had a old injury with like a patellar dislocation that presented with an effusion. It was like 2 years ago, and we MRI'd him, and there was no loose bodies at all. And I always MRI the patellar dislocations with effusions because, like they say, 40% can end up having a loose body that needs scoped out. I don't ever see 40%, but I still do them. And then he came back really recently. I saw him probably in the last 2-3 months, and he was reporting like locking. And it wasn't like, oh, my knee gets stuck and I wiggle it. He's like, literally, he's like, it gets stuck. Like, I can't move it. I have to like wait a few minutes. Sometimes I can like try and grab my leg. Like it was true locking. And then I was like, No episodes of subluxing or dislocating at all recently, got an X-ray and he had a big old chunk sitting like right there. But hadn't had any recent injuries, so you MRI him and that's pretty much exactly what he had, and you go back and look at the old MRI and it was nowhere, so I don't know.
Sometimes they survey like, you know, they can recruit like synovial vasculature and then ossify over time.
Yeah,
Or grow over time, and so sometimes they do change and become more conspicuous. Sometimes you'll see them, so one thing to know about the popliteus tendon, I tell residents this all the time, is that its tendon sheath communicates with the joint. So particularly in old people, we'll see like osteochondral bodies back here, posterior to the tibia. Because you know these little osteoblasts that break off, and then they can get embedded within the popliteus tendon sheath, and we know the popliteus muscles back here. So because the tendon sheath of the popliteus communicates with the joint, anything that's floating around in the joint can get embedded with them. So you can look posterior to the tibia for some of those things. Sometimes they may be embedded there, hiding. But yeah, I think that's it for time. So hopefully that was useful. I'll be back in September, I think, and that's gonna be more of a didactic talk because I have a shoulder talk made, but it's gonna have a lot of cases and stuff. We'll talk about the cuff and the labrum and just basically how to evaluate them and search patterns and stuff like that.
that's awesome, it's gonna be
No problem, thanks.
great.
Look forward to your
Now
next
you
phone
can
calls.
stop the Zoom if you want. Thank you.
No problem.